Good. Well, another very nice presentation there from Frank Arco, who also, as you can see, is a proponent of intravascular ultrasound, which I certainly think is very helpful in knowing when the coarctation has been sufficiently well treated. Dr. Khanna, am I right in saying that that is the last presentation in the session?
Yeah, that's right. And we can have discussion. We have a good panel here. Yourself, Dr. P.C. Gupta, Dr. B.C. Srinivas, Dr. Dayasagar Rao. So we have many people here. We can discuss.
Excellent. Well, why don't they say something? Because I thought that all of the cases shown could easily have gone into the Ironman session next. They were great cases.
Right. I mean, I just want to, the last presentation by Dr. Arco was very good. And normally, we have a different strategy. We normally pre-dilate, or many a time we don't even pre-dilate coarctation when we are using stent graft, but we use the stent grafts which are typically made for coarctation. These are the CP stent grafts, which is the XIII platinum stent graft, and they are mounted over a bib balloon, which is a balloon in balloon. So the inner balloon actually fixes on the coarcted segment, and the outer balloon actually is a longer balloon, and it fixes the aorta so that the stent doesn't move and the balloon doesn't move while we are dilating it. So the way we do it, that we first fix the stent graft from the outer side on both sides, and then we dilate the inner balloon, which will fix the stent graft. So this is how we do it, and we actually do not require a pre-dilatation, and we can be very sure of the position of the stent, and we can also deploy this coarcted, the stents very accurately and with the proper sizing in coarctation. I would like to have experience of maybe Dr. B.C. Srinivas and Dr. Gupta, because we do a lot of this coarctation in India, and we normally put stent grafts. Many times we don't even put stent grafts, we just use a bib balloon to dilate these coarctations. And our results are very good in these situations. So Dr. Srinivas, what would you?
Yeah, we also are using bare metal stents actually. Initially we used to dilate with balloon alone, but we do use bare metal stents to treat it. But yeah, covered stent would be the best, no doubt about it. I would agree with you.
And what about the use of bib balloon, balloon in balloon versus a plain balloon dilatation?
And it's always an advantage to use balloon in balloon rather than single balloon, no doubt about it.
Dr. Gupta.
Yeah, hi. I really don't treat much of aortic coarctation, but yes, I've been involved in a few cases, one of which was a rupture of the aorta following balloon dilatation. And fortunately, we had covered CP stents in the cath lab, and I was able to help out the team deploying 2 of those to salvage the patient. Then we have seen surgical complications. Patients either following a balloon dilatation or following a surgical repair coming with large pseudoaneurysms, and where we've gone in for open repair of these patients. And for patients who we are going in for a redo surgery, it's a real messy job.
Yeah, and that is why the use of stent grafts as a primary strategy is a good strategy. And if we can use a balloon-in-balloon stent graft, and a balloon-mounted stent graft is better than putting in a self-expanding stent graft, because it does tend to has a potential to migrate or milk on either sides, and then it becomes a problem. Dr. Reed, what are your thoughts about it?
Well, it's interesting because I heard just now a colleague here comment that there are occasionally pseudoaneurysms. My understanding is that, particularly in the past, cardiothoracic surgeons used to put a patch onto the coarctation, and it was this anterior patch that's had a false aneurysm. A friend of mine was treated by local surgeons with coarctation, and he had 2 or 3 operations over the years, eventually getting infection. And yet he survived that because he turned up in Geneva on a skiing holiday and ruptured, fortunately, at a center who were able to treat him endovascularly. I think this is a territory which is not really established yet. What would I have if I were a young man and a coarctation? Would I have open surgery or would I have endovascular? I think I would probably still have endovascular, but I think the jury's out because it's not always an ideal treatment. You can get rupture, as we've heard. And I've also seen a patient, a young girl, who was being treated with a bare metal stent, and she had a dissection all the way down into her iliacs. So it can be very complicated in treatment. I think you've got to be doing it in a center regularly. I think IVUS helps. And I think you don't over-treat. I think my biggest comment is not to over-treat coarctation.
And your experience with the PIP balloon versus a plain balloon dilatation? Because the plain balloon tends to move and it creates a lot of chances for dissection.
I've never, ever treated coarctation with a balloon alone. It's always been with a stent or covered stent.
Okay. So if there are no other questions, can we move on to the Iron Man? Dr. Reed, can we proceed to the next session?
Absolutely.